Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features an expert discussion focused on the use of Regorafenib and TAS-102 for patients with metastatic colorectal cancer. This episode is part of a larger program consisting of a podcast series focused on later-line treatment options for patients with metastatic colorectal cancer. During this podcast, Dr. Joleen Hubbard from the Mayo Clinic in Rochester, Minnesota, and Dr. John Marshall from Georgetown University Hospital in Washington, D.C., discuss optimal treatment sequencing and dosing and key adverse events that may influence treatment decisions with Regorafenib and TAS-102 for patients with metastatic colorectal cancer. Please visit the show notes for this episode for a link to the complete program, including downloadable slide sets and additional coming expert podcasts. Now let's get started and hear what Dr. Hubbard and Dr. Marshall have to say on this important topic.
Hello, my name is Joleen Hubbard. I'm a GI oncologist at the Mayo Clinic in Rochester, Minnesota, and I'm joined by my good friend, Dr. John Marshall.
Hey, Joleen, and thanks for including all of us in this together. My name is John Marshall. I'm a GI oncologist in Washington, D.C. at Georgetown University. We have a lot to share in terms of managing colon cancer and particularly later lines of therapy. So maybe, Joleen, talk to me a little bit. I've gotten away from this concept of lines of therapy in colon cancer. And yeah, there are traditional first line, second line, third line, but we do a lot of treatment beyond progression with certain drugs, and we re-challenge. And so instead of it being linear, it sort of feels like a chess game to me. Maybe what's your thought on all of that?
Yeah, I completely agree, John. Typically, we start off with a doublet or triplet systemic chemotherapy regimen, such as FOLFOX or FOLFIRI or FOLFOXIRI, and then we're adding a biologic to those agents, and then usually transitioning to a maintenance therapy with a fluoropyrimidine plus a biologic. And, we kind of use this strategy off and on, and we're challenging with either FOLFOX or FOLFIRI until patients have pretty much declared their cancer is resistant to those treatments. And then we come to drugs like Regorafenib and TAS-102. And I think that's the current paradigm, but I would challenge a little bit of the paradigm that we need to change. And so, Jenna, I would ask you, are you recycling the cytotoxic chemotherapies, like FOLFOX and FOLFIRI, making sure they're completely exhausted and re-challenging prior to using drugs like Regorafenib and TAS-102?
No, I'm really not, honestly. I sort of classify, after first-line therapy, there aren't that many choices, depending on an individual patient's molecular profile. There aren't that many choices that will generate a response, a regression of cancer. And so after that initial response, where, we're seeing, 50, 60, 70% response rates, maintenance therapy, if we're lucky, can last a year or more, I don't necessarily need another response. Stable disease is perfectly fine. And when you do keep going back to the well with these more traditional cytotoxics, I feel like that's sort of fatigue and side effects, maybe liver damage without clear benefit. So I tend to hold my re-challenges, which would be on the list of possible additional response for later lines of therapy. And if you've got, things, obviously an MSI or a RAS or a BRAF, HER2 now, you've got agents where you can get responses again. But in the absence of those, really beyond first line, response rates are very low. So I would tend to use the Regorafenibs and the TASs in this window, saving my re-challenge for later.
Yeah, that's the strategy that I've been using recently as well. particularly based off of the results of the reverse study, which are now trying to be confirmed in the reverse 2 study. But the concept of using something like regorafenib and in a true third-line setting, the reverse study actually showed us we might get better benefit using regorafenib in a true third line, as opposed to waiting until our cytotoxics are re-challenged and completely exhausted. Yeah. Have you been seeing, benefits by using either regorafenib or TAS-102 earlier?
Well, honestly, it's the only time I really feel like I do see the benefit, or at least see the maximum benefit. That patient who is declining, PS2 on the way down, particularly Rego really doesn't work in that patient. There's no sense in trying it. So it is that patient who's still really quite functional, working, maybe wants the break from the infusion unit earlier in the course of treatment, where I think Rego is the right time to play that drug. And now that we have the redose strategy of starting low, 80 milligrams, see them back in a week, 120 milligrams, see them back in a week, and keep escalating to 160 if they tolerate, that's just such an easier dosing schedule. And I have to say my clinical experience with that is much better. Patient experience is much better. And the value of, say, 6 months of stable disease with a novel therapy really is quite useful in the overall chess game and the overall strategy. So, I really do think the error in our ways has been thinking of these drugs as, salvage last line, when in fact I see them much more as bridges or pauses between the more traditional therapies.
Yeah, I think you bring up a couple of good points there. I mean, one, when you are, waiting until the very end of all lines of treatment before introducing drugs like regorafenib or TAS-102, in the patient's performance status is declining, you're right. That's the time where patients are not going to benefit. But I think that we are so used to, as a society, with when we had only FOLFOX or FOLFIRI with our biologics for so long, that people are waiting until the end lines of therapy to use these. And I agree, we could have much better success using them a little earlier on. I think you also bring up another good point with the redose study and showing that, there's much less toxicity and abrupt onset of side effects when we are using this dose escalation strategy. And I think we really need to get the word out there that this is really the way to go, to use this drug safely without very severe and sudden side effects of starting out full dose.
Yeah, and I think you and I are bringing up the point that, back in the day when we were hungry for any new medicine in colorectal cancer, we would never leave a drug on the table. And I do think a lot of our colleagues fail to see value in these two medicines. And so will often even just not prescribe them for patients, or have waited too long, as you were saying, till it is too late to prescribe them. So I think it really falls on us to find the proper window to try these drugs, because when they work, as many as a quarter of the patients we try them in will have 6 months or more of stable disease. And now with, the added data with TAS plus Bev, we've got some first line data there. We've got some more studies looking at TAS, Bev, and other combinations. I do think they're rising in their value. And so what we labeled them as when they first came out, I think is our fault. We didn't use them right. We didn't understand how best to use them. And now that we're learning, I think their value for our patients is clearly increased.
I would completely agree. So, we have these two options, and I love your concept is using these as a bridge and giving them some time off the more traditional cytotoxic chemos that we use. When you're making a decision using regorafenib versus TAS-102, do you have key things that you have in mind when you're trying to choose between one or the other?
I like the concept that our colon cancers have a lot of drivers, but they're not strong drivers. It's not like we have the Suez Canal and our drugs are one big freighter in the middle of the Suez Canal. It's more like it's the Mississippi River Delta, and we've got one branch of that delta blocked, and so all it needs to do is go around through another path. Well, Rego hits a bunch of pathways, and it's possible that it may be a different pathway for our different patients. So I like the idea of switching up mechanism of action if prior tolerance allows me. So I like to use Rego early in these patients for that reason. TAS I do see as a chemotherapy. A fluoropyrimidine works differently, and so a different mechanism of action. I like using it with Bev when I can get away with it for insurance reasons, that Bev beyond progression strategy. I don't know what you're doing with this, but if I use, say, Cape Bev as my maintenance first line, and then let's say I go to maybe irinotecan or oxaliplatin second line, and I'm going to go to maintenance again, I sometimes will use these drugs as that maintenance. So not necessarily at progression, but use them as sort of maintenance 2.0 when I have that opportunity. Patient who relapses after a metastatectomy with small volume disease, small volume lung disease, where I don't want to use a lot of major cytotoxics. To me, this is a nice time to consider using these oral therapies, as I say, as sort of maintenance 2.0. But I tended to use Rego first. I usually use TAS with Bev later. But I also will change that around depending on the patient in front of me.
Yeah, I love this concept of maintenance 2.0 because it does make a lot of sense. If you use Kate Bev as your first maintenance and then they progress on that, you go to your second line. It kind of doesn't make a lot of sense to go back to, 5-FU or Cape with Bev when they progressed on it previously. So I love that concept of TAS Bev as a second sort of maintenance strategy. It makes a lot of sense to me. I would also say, there's certain populations or certain patients where I think, maybe more appropriate to use Rego versus TAS. For instance, if someone is, having trouble with, eating a little anorexic, Regorafenib with its side effects of decreasing appetite, probably not the best one to use first. Versus someone who's had a lot of cytopenia, so say their marrow is really sensitive to cytotoxic chemotherapy. TAS-102 certainly will cause some cytopenias requiring dose reduction. So that may be a patient's more appropriate for regorafenib up front as opposed to TAS-102.
No, I totally agree with that assessment. A little hand foot here, a little, anorexia there, and you shift one way or the other. I was curious, are you all doing any sort of novel dosing with TAS? Because the traditional of 2 weeks in a row, it never really made a lot of sense to me. And so when people come back with a cytopenia before cycle 2, I've often gone to every other week instead of a dose modification. Have you fiddled in that way with this drug?
I have done that with, some varying success doing the every other week strategy. I think it just gives their marrow a little bit of more time to recover. I think it gives the patients a little bit more time to recover because they definitely do suffer from fatigue with this medication. And I haven't noticed it in terms of changing outcomes. I think the outcomes are fairly similar, whether you do 2 weeks on, 2 weeks off, versus versus a 1 week on, 1 week off. And actually, the 1 week on, 1 week off, if you use it with Bev, it kind of fits that strategy a little better too.
Yeah, exactly right. Perfect fit. Anyway. All right. Well, thanks for chatting up our refractory colorectal cancer discussion and really focused on Rego and TAS. And I so respect your clinical instincts and your knowledge of the data. And so it's good to see that I'm aligned a lot with what you're doing. It reassures me certainly that my instincts and yours are aligned, and hope this helps others who are out there dealing with the same issue.
I completely agree, John. This has been a pleasure. Thank you very much for your insight and expertise.
Thank you very much, Dr. Hubbard and Dr. Marshall, and thanks to you, the listeners, for joining us. As a reminder, to view the full program and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.